what I really want you to do is focus on the sorts of things that you need to think about in all of your patients. All right? Talk about barriers and solutions, and try to reinforce the development of the habit, which is the most important thing. If you develop the habit of always evaluating this each time you see a patient, then none of the balls get dropped. Okay, so definition. So very quickly, you're aware of this primary prevention. If that works, then you don't need to do anything else because you prevented it, right? And then that's based on a person's demographics, age, risk factors. The other thing, secondary prevention, think of that as debris. I'm making sort of a reference here. It's kind of an old reference. Now I'm thinking I need to change that. A reference to the Dutch boy and the dikes, you know, where secondary prevention would be you see the debris on the ground and you say, hey, we need to do something before this thing breaks loose. And then tertiary is the Dutch boy who's now got his finger in. You don't want to be the Dutch boy. You want to be primary prevention. In other words, you've done everything right. You found the polyps. You dealt with the breast lumps. So why do it? Give me some reasons why you think we should do it. They're right there in front of you. So the reason this talk is called an ounce is because it's that old saying, an ounce of prevention is worth a pound of cure, right? It's much easier to prevent a thing, for the most part, than it is to deal with the thing. And unfortunately, in today's medical climate, when we say easier, we mean cheaper, right? So it's much less expensive to deal with colon polyp, and you can just clip it rather than when it's huge, you can't clip it, you have to go in, do a surgery, maybe it's cancer, now they have to have treatment. Okay, so morbidity and mortality, presumably two things we'd like to avoid. And to minimize healthcare costs, which we just talked about, and to minimize harm. So if you can do that, you should probably try. This isn't necessarily in any particular order, but obviously number one and number three are really sort of the same. All right. So what do you want to screen? These are three things that are important. There's a whole list of other things. Because obviously there are tests that exist for many conditions. And you can go through and test for every single thing. But you only want to test for things that sort of matter. And matter means there's a burden from it. So going through and checking everybody to see, we're creating a screening test to see if anybody has, say, dark colored spots on their feet, but there's no morbidity or mortality or anything associated with it. There's no burden, so you wouldn't do that, even though you can create a test to find it, okay? Quality of the available screening. In other words, there is a test that's available that people will submit to. That doesn't cost too much, it's not too expensive, it's not too cumbersome. All right. The main thing about that is, think about a condition that required an extensive surgical procedure to screen for. Even though you could use that surgical procedure to find the condition and treat it early, everybody doesn't want to get cut open to find whatever this is. So even though the screen works and it prevents the disease, the quality of the screen is not so good because the problems associated with going through that procedure. All right. And then the effectiveness of intervention. It doesn't make a lot of sense to screen for things that early intervention doesn't help with anyway. That's kind of a common sense thing. So, as always, one of the main things is money. If it's too expensive, Cam is in the room. Cam is in the building.
How's it going? Just got the email that you need me for something.
Have you looked into the UAB email stuff, like how they have to get?
On their phones? Yes, it's an app we'll have to download and install and configure. So when you guys have time, we can actually do that.
Okay, so if you guys need help, that's the guy I was talking about. All right. Actually, do you want to give your cell phone number out? Everybody
Yes,
put
I can
this.
do that.
Everybody put this in their phone. I'm not kidding. He
Yes, and
actually
use it.
likes this. He
I
likes
do. I enjoy this. It's true. And a couple of you guys have actually done it.
What's your number?
It's 205 245
No prank calls, people.
4610. Actually, I don't mind phone calls. That's fine.
Yeah.
All right. Yes. Cam.
He feels like he has friends with you guys.
It makes you think I do. I don't really know, but you know.
Wait, bring him up here.
Yeah. Cam. CAM.
I created that several people.
All right. Yeah. So
All right,
call
so
me when
please
you
put
guys are
these
ready.
in your
We'll take care of it.
phones, text him. So seriously, when the printers aren't working, actually, here's another thing for you. The
Great.
printers aren't working in the call room, text Cam.
Yeah. I'll come.
The fact that none of you can get to the clinic right now can. Nobody can get the clinic stuff on the 4 computers down there.
Okay.
I don't know why, they used to be able to. Can you find out why it is that they can't?
Wait,
get
they
the
used to
clinic
be able to, or they never worked since they moved over there, those
stuff?
4
No,
computers?
we checked, I did it once to
Oh,
make sure.
I'll look at it right now.
Okay, so he's the guy, when the computers are not working in the clinic, he's the guy. Even when he's at Selma, you guys can text him.
Exactly.
Pooja, when you're getting kicked out day after day,
Let me know.
he's the guy, all right? So
We mean out of the system, not out of the residency.
Thank
Oh, that was pretty bad. That was pretty bad.
You're killing me.
Okay, so going back again, one of the main motivations is money.
You guys.
You want to keep it cheap and keep it right when talking. Side note bias, there's several different kinds. Lead time bias means more disease time. Somebody tell me what that means, Dr. Sarmadha. Lead time bias, right there, more disease time. What does that mean? Explain that statement.
I think the disease was discovered later on, so you think that.
You get a consult or a referral? Referral, yes ma'am.
The referral means you say, right?
Okay.
I'd say no referral.
You guys always get this confused.
Well, if there's a test that makes you diagnose the disease earlier, it seems like you have a longer survival because it was diagnosed early, but it's not really longer survival. If it was, if it was diagnosed later, he would have still died at age 80, but if it was diagnosed at 30, you think he had 50 years instead of being diagnosed at 40 when he had 40 more years.
In other words, it's basically, yes. So lead time bias means you diagnose it earlier, it really doesn't make any difference, it's just more time with the disease. And so if you looked at that data just on the surface, you might say, okay, when we use this test, we have a 50-year survival. You have to analyze the data a little bit more completely to get around that type of bias. What about length time bias? Dr. Sethi?
Length time. So if it's like you know the condition exists for a longer time, that does not really change the prognosis of the outcome.
So what it has to do with is the statement that's under it, is less aggressive. In other words, if you create tests that in some ways finds people who have less aggressive disease, then they have more time, more survival, better survival, but the type of disease they have is a bit different than the more aggressive people. So it may look as if the screen helps, but really it's just that their disease is inherently less aggressive, okay? And then compliance bias. What about that? We don't usually have that problem. The people who are compliant with studies and doing all these things, maybe they're the type of patient who tends to be healthier because they're more compliant in general. Okay, that was a little fuzzy. All right, so how do we get at the recommendations? That's the main thing. Why? Why are they important? Why do they matter? Well, there's several ways. One, group recommendations. People who are experts sit down, panels of experts, or people who are thought leaders in their particular industry or specialty. They sit down, they look over the data, and they say, this is what's important, this is what should be done, and this is why. So they take a look at things that are common, tests that we can do that have good predictive value, and that's how they generate it. Okay, so don't forget about sensitivity and specificity. Those are one of those things that are very important when it comes to testing and results. All right, so recommendations just very quickly. So we're talking about data quality. We're talking about the data. So the recommendation levels. So recommendation levels are based on data, which is the next quality, and quality of data. A means it's strongly recommended, means they got good evidence. B, what's B? What's, okay, what's H? Okay, so good evidence that outcomes are improved, B greater than H. We looked at the data, everything we looked at, we do this, benefit greater than harm. Now B, recommended. Okay, well, at least there's fair evidence that B is greater than H. You always want B greater than H. You never want H greater than B. You don't really want H equal to B. Forget H, you want B. More B, as much B as possible. C, no recommendation for or against. So there's fair evidence that can improve outcomes, depending, kind of depends. And then D, they're saying, no, harm is greater, don't do it. And I, they don't say anything, we won't have enough data to review. Remember, the groups sit down, they talk about things, and if they sit down and they look, and only one of the guys has a sheet of paper in front of them, and the rest of them just have their Starbucks, they're like, this is not enough. All right, so again, evidence quality is what those recommendations are based on. Good means we got good studies, appropriate populations, consistent results. So we don't want to take, say, a small, Dutch village and take the milkmaids and say, we did a study on, 37 Dutch small village milkmaids and generalize that to everybody else. That's not what you want to do. You want to use studies that have appropriate generalizability. I don't have anything against Dutch milkmaids in case any of you are related to Dutch milkmaids. I happen to like Dutch milkmaids. Fair. Good evidence, lack of studies, and generalizability, we just said. And then poor, whatever it is bad juju. You don't want to base it on that. Okay. So, ideal D, yes ma'am.
Before we leave evidence, you're not allowed to answer this question. So we did a couple journal articles last week. Does anybody want to talk about how one of those articles fits into this? I mean, I'm going to tell you which article it was. Yeah, he presented it, that's
Is
why
it
he's
good?
not allowed to answer. So
Good.
how
It's
is
a good.
it, how is it good? Like if you were the panel, so you say it's a good study. Go back to the previous slide, please. What level of recommendation would you give it? Yes, it was CT, so low radiation CT screening for lung cancer in patients over 55 who have smoked at least 30 and a half years.
B. B.
What did they say? Did they say A? In the, because it became,
They haven't given ABs like 1A, they just said they recommended.
I wouldn't be surprised if it gets an A, because you very rarely see a randomized controlled trial on screening. If you look at his stuff, the next page, most of the time it's observational and expert opinions. There just aren't a whole lot like that. So anyway, thank you. I just wanted to bring that back to stuff.
Made it tiny.
Time.
So it's very important to actually look at these things, because when they sit down, these groups sit down, whoever the groups are, whoever the groups people believe in, if you're a specialist, then you may believe in your group. The ID guys may believe in their ID.
Essay.
But, yeah, okay, whatever. And the GI guys will believe in their GI essay. But overall, there are other groups that sort of are bits and pieces of the other groups, and they use the same recommendations, okay? They apply it differently. Obviously, if your mortgage is gonna be paid, is gonna depend on a particular thing, you might be more inclined to say that thing than anything else. I'm not saying that ever happens, I'm just saying. All right, so ideal disease features. Remember, we gotta talk about disease features, we gotta talk about test features. And disease features is something that has significant public health impact. So give me an example. I mean, it's gotta matter, right? Black spots on the feet don't matter. So colon cancer, that matters. We can identify that it significantly impacts public health. We can identify there's something we can do about it. There's an asymptomatic period when the detection is possible. In other words, if you create a test, and as soon as the person develops a condition, they're already toast, probably the test's not gonna help much. So you need an asymptomatic period. That's no small thing. Third thing, outcomes are improved during the asymptomatic period. In other words, you identify, say this is a problem, we do something, and they're better. But we can use your colon cancer example again. All right, so now that was disease features. Now these are the features of the test. You want it to be sufficiently sensitive during asymptomatic. So what does sensitive mean?
To rule out
Okay.
anything.
Pick up something when it's there. Pick up a disease when it's there.
And then specific means,
Rule out.
To rule out anything.
okay, so the formula for sensitivity is,
True positive upon true positive plus false negative.
okay, so the people who truly have it over everybody that says have it, or everybody that actually has the disease. So you want the disease to be sensitive enough to pick up during asymptomatic. You want it to be specific enough so that you don't get so many false positives that you're testing everybody. And it has to be acceptable. So anything that involves reaching into an orifice with anything larger than about a finger, most people aren't going to be excited about. That's probably your cutoff. So when you finish your residency and you go out and you create an entirely new test, and it finds anything in the world, if it involves an orifice and anything bigger than this, it's probably not going to go over. Okay? I'm just helping you out ahead of time. Okay, now the population. So we talked about the test, we talked about the disease, this is the population, ideal features. So it needs to happen enough that it's important enough for you to go out looking for it. If it's something that only happens, 0% of the time, then it's just not enough, it's not impactful enough for you to even look in that population for it. Now, a test may be good for a certain population. And give me an example of what you think this means. This is a pretty important thing when it comes to screening.
Breast cancer.
Okay?
Breast cancer in men.
Okay, there we go. So, breast cancer screening is important. It's an important thing, but you can't go screening every single person, because then it's not such a good test anymore. You have to be very selective with your population. Sometimes being selective with the population means adjusting for gender, which you just did. What else? Age. What else?
And then in the CT scans, we adjusted for smoking status.
Risk factors. All right, very good. All right, race. Wait.
What?
Like in some diseases are more common in some populations.
You trying to give this a racial spin?
Can you think of an example, though, where there's a racial screening difference?
Some diseases are Ashkenazi Jews more common. But we don't see
Osteoporosis.
Right, but
G6PD, yes.
This is a good time to tell a Jew joke.
Now you watch your mouth, sir.
Just so you know, you are being recorded.
Yeah.
Okay.
so actually Japanese are actually screened for gastric cancer because it's really high over there, and they actually do find it earlier,
There you go.
and they can actually treat it now.
Right.
Because
I
when
actually
you
read
catch
something about
gastric
it.
cancer much earlier, you can treat it. So
There you go.
according to that.
Except Japanese is not a race. It really is.
Right. What I mean is,
Well,
And it's Asian, just like you.
All right. So now let's talk about the guidelines.
We need to move on.
Okay, so I'm just going to kind of go through them. Do you have any questions? Talk about it. And then we'll just talk about it a little bit more at the end. I've given you a handout. You'll see one side is sort of the screening test, little X marks over age and things like that. The other side is just a list of sort of caveats and details, okay? So really just very quickly. So AAAs. Tell me what you think about AAA.
Gender discrimination.
Male.
Okay. So who gets it? Male. So when you look at this slide, the main thing to remember, and this is one that gets dropped off fairly easily, because it's not a passive one at all. You have to literally remember. Some of the others sort of happen, but AAA. 65 to 75, meaning if they're younger than 65, technically you don't do it, although there are some recommendations for 60 to 64. But let's just say 65 is the age. History of tobacco use. I've told some of you this. What counts as a history of tobacco use?
so more than 100 cigarettes in a lifetime.
100 cigarettes in a lifetime is kind of what they're using. So 100 cigarettes in a lifetime, they get a AAA.
And how many packs is that?
5.
So, in lifetime, not per year, not whatever, that's lifetime cigarettes. They had 100 and you can kind of gauge that. People either kind of, then they need an ultrasound of their organ. Yes, it's paid for. So recommendation C, 65 to 75. So remember we're talking about the strength of the recommendation. So it just kind of depends. Remember also, each time we go through one of these, we're talking about screening. Screening means looking when what?
There are no symptoms.
We're not talking about diagnostics, which means screening. Obviously, if somebody comes in and they're 40 and they have a pulsatile mass in their abdomen, that's not the guy we're talking about. We're talking about the guy who comes in and he's 66, he has no symptoms, and he's just there for an office visit. Doctor.
If he's 77, as a clinic patient would be a smoker, he's not been seen previously or screened previously, yes.
Well, technically, the recommendation is 65 to 75. Would I screen that person? Maybe.
My question is, 5 5-pack life history is so low.
Everybody-
Well, I know the cost of the test is low, and so it